Hello guys, welcome to our channel. Today we are going to discuss about the pharmacology part 2. In this part 2, I am going to discuss about the autonomic nervous system and also central nervous system and analgesics and also anti-chemotherapy drugs and their side effects. So let's start with the first central nervous system. In the central nervous system, we will go by the important topics such as Alzheimer's disease. So when we are discussing about the Alzheimer's disease, this is mostly due to decreased acetylcholine. So what we are going to do, we are going to give the anticholinesterase. What it will do, so when you are going to block the anticholinesterase, so it will not going to degrade the acetylcholine, so that acetylcholine will be increased in this patient. So what is the drug of the choice? Donepezil is the common drug that we are going to use, and also other drugs such as rivastigmine, galantamine and taurine can be also used. And NMDA blocker or NMDA antagonist, that is a memantine, is also going to increase the neuroprotective agent. Okay, so it will also relieve the symptoms of the patients suffering from the Alzheimer's. Next, coming to the Parkinson's disease. Parkinson's disease, we all know that it is due to decreased dopamine. So it is divided into the two parts. One is less than 65 years old and other one is the more than 65 years old. So those who are less than 65, we are going to start them on the dopa agonist. Okay, that is the dopa 2 agonist. What are those drugs? Pramipixole, propinerol or the roticotin. Okay, this is the patch form. And what the side effects associated with this pramipixole? Usually it is going to increase the impulsivity, gambling and sexual attitude of the patients, and fatigue edema is also seen. More than 65 years old, we are going to start the patients on the levodopa plus the carbidopa. Carbidopa is a special decarboxylase peripheral inhibitor. Okay, so this is going to block the peripheral conversion, not in the central nervous system, it's peripheral conversion system. So 4 is to 1. Okay, 4 times of the levodopa, only 1 time of the carbidopa, so that the peripheral conversion will be blocked. And next side effects associated with this one: dyskinesis, orthostatic hypotension, psychosis and the glaucoma. The most important, you have to remember orthostatic hypotension. Next, whenever you see the patient is suffering from the psychosis and the glaucoma, the levodopa or the carbidopa should be not given. Next, if the levodopa is not working in the patients such as falls, dysarthria, dysphagia, motor fluctuations. So even though you are giving the levodopa, it's not working for these symptoms. What we have to do? Then we have to start the patient on the amantadine. What is this amantadine? Again, it is a NMDA blocker. It will increase the dopamine and also it will increase the anticholinergic activity. The symptoms such as side effects, libido reticularis and the edema will be seen in this patient. Right. Next, other drugs what we can add in the Parkinson's patients: MAO inhibitors. Okay, this is a monoamine oxidase inhibitors, that is a selagelin, and COMT inhibitors, that is for the entacapone or the tolicaptone. So this tolicaptone is highly liver toxic and entacapone is used for the on and off phenomena to decrease the Parkinson's symptoms. Next, coming to the migraine therapy. In the migraine therapy, the first line therapy is the NSAIDs. Whenever you see the patient is always tells that the headache, so we are going to start on the NSAIDs. But drug of the choice is the triptans. What are the common drug that we are going to use, guys? Sumatriptan. 5-HT1B and the 5-HT1D blocker is the sumatriptan. It is a potent vasoconstrictor. So lasmiditan is a 5-HT1F blocker and it will decrease the vasoconstriction. So those who are suffering from the angina or the MI or the cerebrovascular disease, we are not going to give the triptans because this is the vasoconstrictor. And also in the patients, those who are with the pregnancy in the first trimester also, we are not going to give. But if they ask the second trimester, third trimester or overall the pregnancy, still the triptans are given for those patients. And ergots is contraindicated because highly vascular ischemia, same vasoconstriction but highly ischemic. And other drugs that are the very commonly where we are going to act on the direct on the receptors. What are the receptors? CGRP receptor. The examples are olkigipactan or the ramigipactan, and next uberogipant. On these drugs, either the treatment or the prophylaxis we can give for those patients. And whole only prophylaxis, that is a propranolol beta blocker, is the drug of the choice. Topiramate, amitriptyline and onabotulinum toxin A is the common prophylaxis. CGRP inhibitors like eptinizumab or the fremanizumab, galcanezumab and the Ernumab. This is blocking the receptor and used only for the prophylaxis. This is for the treatment and the prophylaxis. This is only for the prophylaxis receptors. Next, coming to the anti-epileptics. Let's see one by one. Valproate. Okay, sodium valproate. Sodium valproate is a very widely used drug. Why? Because it is going to block the sodium, calcium, GABA transaminase, and overall this effect will increase the GABA inhibition. So GABA will decrease the seizures. So what are the examples we commonly use? GTCS, generalized tonic-clonic seizure, myoclonic jerks, and also absence seizures, Dravet syndromes, or the Lennox-Gastaut syndrome also we can use for these patients. But it is a highly teratogenic, vomitings, liver toxicity, and rashes, alopecia, pancreatitis, obesity, PCOD, high ammonia, and tremors will be seen in these patients. Antidote is the carnitine is a common drug we can use for this patient. And next, ethoxamide. Ethoxamide is going to block the T type of the calcium channels. It is going to use for the absence seizures, especially in the developed countries. And coming to the carbamazepine is used for the sodium channel blocker and Rolandic seizures, partial seizures, trigeminal neuralgia, and even SSPE. We can use the carbamazepine. SSPE is a measles complication, and the side effects are Steven Johnson syndrome, agranulocytosis, eosinophilia, decreased sodium, ataxia, and the diplopia will be seen in this patient. Okay, next, phenytoin is also sodium channel blocker. It is used for the status epilepticus and also class 2A anti-arrhythmic drugs also we can use because it is a sodium channel blocker. Next, common side effects are hirsutism, nystagmus, teratogenicity, acne, gingival hyperplasia, decreased vitamin D, decreased vitamin K, osteomalacia, nasal bleeding, and also folate deficiency and ataxia will be seen in this patient. Topiramate is a GABA agonist. It will increase the GABA, migraine prophylaxis, and also some seizures and weight loss, renal stones, and metabolic acidosis, and the glaucoma is the common side effects. Next, the drugs that we are going to use. West syndrome is the ACTH. West syndrome with the tuberous sclerosis, vigabatrin or the cannabidiol, or the Levin-Gastaut syndrome and the Dravet syndrome, cannabidiol can be used after the sodium valproate, and Levin-Gastaut syndrome again Rofinamide can be also used. Neonatal seizures, phenobarbital is commonly used drug. Coming to the pregnancy and the epilepsy. So whenever you are going to start the patient with the pregnancy with the epilepsy, already diagnosed patient, if the patient is on the treatment before the conception, try to change when they wanted to conceive. Like levetiracetam can be given for this patient or the lamotrigine. The best drug is the levetiracetam. Why? Because it is going to block the synaptic vesicle protein of the neurotransmitter, and lamotrigine is going to block the sodium and the decrease the glutamate activity. The excitatory activity will be decreased. But if she is already on the treatment but conceived, then please continue the same drug with whichever phenytoin, carbamazepine, anything you can continue because it can cause the refractory seizures. If you change the dosage, it can cause the refractory seizures. So that avoid that, we can continue the same treatment if already treatment and conception is happened. Eclampsia, this is the pregnancy induced hypertension eclampsia. We can use the MGS44 as a IV drug we can use for this patient. Next, other types, barbiturates and the benzodiazepines. What is the difference between this? Barbiturates is going to be the increased duration of the GABA. Okay, it will increase the duration of the GABA, and it is an enzyme inducer, and porphyrias patients it is contraindicated. Next, coming to the patients, coming to the benzodiazepines, it will increase the frequency of the GABA. So, which is better? So the benzodiazepines are the better. That's why we are going to use the lorazepam or the clorazepam immediately for the patients of the seizures. And it is not an inducer, and liver toxicity is highly seen. And the antidote is the fomepizole, and here antidote is with the alkaline diuresis. Okay. Next, the other drugs, pentobarbital is a short acting, phenobarbital is a long acting. Again, here lorazepam is a short acting, clorazepam is a long acting. And ALS, the aminotropic liposclerosis, the patient common drug we are going to use the riluzole, NMDA blocker, and baclofen for the GABA inhibition that we are going to use. Edorovant, tofersen is a SOD1 gene inhibitor, and sodium phenylbutyrate and taurusidol. These drugs can be used for to decrease the neurodegeneration of the patient. Next, coming to the anti-gout therapy. So, anti-gout therapy, remember it is gout is divided into the three types. Okay, acute, chronic, and the pseudo gout. Acute gout, the uric acid levels are normal. So we can give the NSAIDs. If no working, then we can add the NSAID plus colchicine. This colchicine will decrease the neutrophils migration. Okay, inflammation will be decreased. Next, coming to the chronic, uric acid levels are significantly increased. So we have to start the allopurinol. Further uric acid levels are to be decreased. So that's why the xanthine oxidase inhibitor like allopurinol should be given for this patient, and other drug is the febuxostat. Pseudo gout, that itself not the uric acid, so uric acid will be normal, and the drug of the choice is the NSAIDs. Tumor lysis syndrome, you all may have heard. In the tumor lysis syndrome, the actual drug of the choice is the allopurinol. It is given for all the solid tumors. But if you see the raspberry case, it is given for the WBC disorders only. And uricosuric drugs, the drugs that will it is going to excrete the uric acid from the kidney. That those are the uricosuric drugs. The examples is the probenecid, and the common side effects is the urate stones only. Next, the drugs that will increase the uric acid such as thiazides, loop diuretics, aspirin, ethambutol, allopurinol, probenecid, and the alcohol, and beta blockers, isoniazid, and the ACE inhibitors, that is going to increase the uric acid. Which of the drugs that will decrease the uric acid? Fibrates and the losartan, which will be decreasing the uric acid levels in the body. Next, coming to the NSAIDs, it is the arachidonic pathway. You all know that this arachidonic pathway is going to be the cyclooxygenate pathway and the lipooxygenase pathway. So we call this as a COX-1, COX-2, and this is as a LOX pathway. So in the COX pathway, we are going to have the important drugs such as prostaglandin is going to be produced, and this prostaglandin is going to cover all the structures of our body. Okay, not just one, it is going to act on the multiple tissue sites. It is going to act. So same as the LOX pathway, you are going to have the leukotrienes and also lipoxin B4 and A4 we are going to produce. So NSAID is non-steroidal anti-inflammatory. We are going to block this LOX pathway and the COX pathway. So how we are going to block? So NSAID drugs such as COX inhibitors. These are the non-selective COX inhibitors. What are those? Salicylate, aspirin, which is the commonly used drug, acetic acid derivatives like indomethacin and the ketorolac, and pyrrolizolene is the oxime phenobutazine, propionic acid, ketophrentin, and the ibuprofen, and phenamate is the memphanic acid, enolic acid is the thinoxicin. So the most important that you have to remember, salicylates, acetic acid derivatives, and also propionic acid derivatives that you have to remember. The preferential COX-2 inhibitors, those are the diclofenac and the aciclofenac drugs that we are going to use. COX-2 selective inhibitors like celecoxib, analgesic with the antipyretic, poor anti-inflammatory actions are such as the paracetamol or the methimazole and the profenizone and nofopinam. These are the analgesic antipyretic with a poor anti-inflammatory action. All right, next let's see one by one. Acetaminophen is a paracetamol which is an analgesic and antipyretic commonly used drug of the choice. It is a highly hepatotoxic and most common worldwide. This is a highly hepatotoxic drug. If you take more than 10 grams or the equal to 10 grams, it is going to cause the liver toxicity. Especially it is more prone when in the alcoholics, liver disease patients and the fasting patients. Next, on the biopsy, you are going to see the centrilobar necrosis, and antidote is the N-acetylcysteine. And aspirin is another drug which is an anti-aggregant at the low doses, and it is an anti-inflammatory at the high doses. And also side effects such as the gout, Reye's syndrome will be associated with the aspirin, and antidote is the bicarbonate. Next, we have the diclofenac. It is a non-selective COX-1 and the COX-2 inhibitor. It's an analgesic drug. Side effects such as the gastritis, increased sodium levels, thrombosis, and the allergy. So by that, you can understand those who are suffering with the pelvic inflammatory disease, sorry, peptic ulcer disease, asthma, liver disease, kidney and heart disease, we are not going to give the diclofenac. But nowadays it is a very widely misused in the sub-centers and the PHC centers. Indomethacin is for the acute gout, ibuprofen is for the patent ductus arteriosus closure, ketorolac is used for the post-operative pain. Next, anti-chemotherapy, that is a very important, this chart itself very important for you guys. So first, you can see the C place is given at the ear. So cisplatin and the carboplatin is a very ototoxic, and same as the kidneys, it is also nephrotoxic. Next, B at the regions of the lungs. So bleomycin and the busfolin is going to cause the pulmonary fibrosis. Next, D is given at the heart. Doxorubicin or the dexorubicin is for the cardiotoxicity. And T and V, here you can see the taxons such as the plaxitoxin or the doxytoxin and vinclines, vincristin or the vinblastin is going to cause the peripheral nephropathy. And M and F here at the bone marrow, methotrexate and the 5-fluorouracil for the myelosuppression. And N, here you can see that is going to cause a neurotoxicity such as the carmustine and the lomustine of the nitrosoureosis drugs. And cyclophosphamide is going to cause the hemorrhagic cystitis. These are the some of the important anti-chemo drugs and their associated side effects. Let's continue with the pharmacology of the autonomic nervous system. So we have seen that here the parasympathetic nervous system and the sympathetic nervous system. So what is normal? Let's learn. So sympathetic activity. So the parasympathetic activity predominantly it is acetylcholine, whereas sympathetic activity is the predominantly norepinephrine, epinephrine, and also sometimes acetylcholine. Let's see how acetylcholine also. So muscarinic and the nicotinic receptors for the parasympathetic and alpha and the beta receptors for the sympathetic activity. Next, so there will be increased fluids such as the patients will be having the defecation, urination and the salivation will be seen. So it is a relaxed state. During the relaxation only you are going to get the salivation for the food and urination for the relaxation of the urinary bladder and also intestines mass movement which will be going to the defecation and no energy at all. So that's why it is a glycogenesis. The glycogen is going to be produced here and bronchoconstriction and decreased heart rate and erection such as will be seen in the parasympathetic activity. But whereas here in the sympathetic nervous system, the fluids will be decreased, no urination or the salivation, and the acetylcholine and the sweating will be increased in this patient. Okay, so such as that we are going to see that in these patients, what happens? The energy, glycogenolysis, and increased heart rate and bronchodilation and no erections, but the ejaculation is from the activity of the sympathetic nervous system. Okay, so by this we can understand that this is the commonly associated, but this is the commonly associated that the parasympathetic activity is going to increase the what activity guys? The acetylcholine activity, right? So we are going to discuss the system wise parasympathetic mimetics. So what is mean by the parasympathetic mimetic? The mimetic means mimic. It is going to do the same actions such as the muscarinic one is going to act on the CNS and the ENS enteric nervous system. M2 is for the heart, M3 is for the rest of the body. So let's see one by one. So on the CNS, it is going to increase the cognition. Just now we discussed Alzheimer's patients. So donepezil, rivastigmine, galantamine and the taurine. Next, pupils, it is going to have the constriction. So we are going to use the acute closure glaucoma, pilocarpine and the carbuncle for this patient. Next, oral salivation and the Sjogren syndrome. Pilocarpine is a common drug. For the lungs, it is going to cause the bronchoconstriction. Usually, it is a contraindicated in the asthma and the COPD patients. Methacholine and the bronchial constriction, and this is a bronchoconstriction will be caused in this patient such as asthma triggering point. Next, heart, it is going to decrease the heart rate, contraction will be decreased, relaxation is seen. So smooth muscles, the drugs is going to act on the intestine such as increase the HCl secretion and the contraction. These are the M3 selectives. What are those drugs guys? M3 selective means it can act on the urinary bladder also such as bethancoline. So post-operative ileus, post-operative urinary retention, you can give the bethanocol drug. Next, skeletal muscle. acetylcholine and increase the contractions. Okay, so what the drugs commonly we use? Neostigmine for the muscle relaxant, physostigmine for the atropine, the thura poisoning, pyridostigmine for the myasthenia gravis, and hydrophonium for the tensilon test we are going to use. Right? These are the common drugs that we are going to use for this patient. Next, parasympatholytic drugs. What are these? This is going to block the inhibitors of the parasympathetic means it is going to block the ACH. So it is opposite to the normal function. What is the normal function again? Salivation, urination, bronchoconstriction, heart rate relaxation. Though all are going to be the opposite. So CNS will be decreased cognition, decreased acetylcholine. What are those drugs? So called scopolamine. Scopolamine, why we are going to use to decrease the CNS action means motion sickness, narcoanalysis we can use. And pupils we have to dilate cycloplegia. What are those? Atropine, tropicamide, homotriptine, and cyclopentolate. So the best about these drugs are such as it is used for the refractory and fundus test. Okay, refractory errors and the fundus test we are going to use. It is contraindicated in the closed glaucoma and the patients will be associated with the uveitis and syncytial formation is also seen in this patient. Okay, next for the adults we are going to use the tropicamide and for the children we are going to use the atropine because it is a half-life is the 1 week whereas the tropicamate is just 2 hours only. Next, salivation and the oral, decrease the salivation and the aspiration. So we are going to use in the anesthesia, pre-anesthetic position, there is a glycopyrrolate. For the lungs, we are going to use to decrease the bronchoconstrictions. What are those antagonists such as long-acting, intermediate, and the short-acting, tiotropium, acticamide, and the ipratropium for used for the patients of the COPD. And the heart rate, to decrease the heart rate, atropine is used for the bradycardia and IV 1 mg, at least 3 mg should be given. And if it is a 0.5 mg, it can cause the reflex tachycardia. And on the smooth muscles, it is going to act on the HCl secretion, decretion, contraction, and the relaxation again on the M3 of the selective urinary bladder. What are those drugs? Let's see. Talanzepine is used for the peptic ulcer disease. Dicyclomine is used for the antispasmodic, the one which we the commonly used for the females like met. This is the meftol plus. The dicyclomine is the active product, and the solifenacin and the trospium and dalifenacin is used for the urge incontinence and the neurogenic bladder. And next, skeletal muscles we have used for the relaxation and the NDMR blocker. So when we divide this into the amines, these are the tertiary amines and the quaternary amines. So the tertiary amines can cross the blood-brain barrier such as the donepezil and the pilocarpine. And the quaternary amines they does not cross, so that's why they're acting on the muscles such as neostigmine and the urinary bladder bethanocol. Next, sympathomimetic, okay, like alpha and the beta. First, we will see the alpha beta actions. So, alpha 1 is acting on the vasoconstriction, muscle contraction, and the pupil dilatation. Alpha 2 on the platelet aggregation, decrease the insulin, decrease the saliva, and decrease the sympathetic action and remove the neurotransmitters. Beta 1 is for the lipolysis, inotropic activity, and heart rate increase, and renin secretion. Beta 2 is for the lipolysis, lung dilatations, insulin increase, glucagon, and decrease the potassium dilatation of the vessels and decrease the uterine tone. Okay, so when we talk about the epinephrine, it is 1 is to 1000 is given for the anaphylactic acid. 1 is to 10,000 is used for the shock patients, and 1 is to 1 lakh is for the vasoconstriction, 1 is to 2 lakh is for the local anesthesia. Okay, so we all know that this is a direct drug, that is a dobutamine. It is an indirect agonist epinephrine and the isoprenaline, and competitive inhibitor or the antagonist we can say, that is a norepinephrine, which will cause the reflex bradycardia via vagus nerve. So dopamine is, if you given in the less than 2 mg, it is going to cause the diuresis by the D1 receptor. If it is given in the 2 to 10 mg, acting on the beta 1 receptor inotropy, and more than 10 mg, it can cause the alpha 1 activation and vasoconstriction will be seen. Okay, and sorry, beta 3 is for the lipolysis and the bladder relaxation. Epinephrine is going to act on the alpha 1, alpha 2, beta 1, beta 2, and beta 3, mostly on the beta 2. Norepinephrine, alpha 1, beta 1, and the beta 2. Dopamine D1, D2, alpha 1 and beta 2. Dopamine is mostly on the B1, B2 and alpha 1. Isoprenaline beta 1 and beta 2 is equal. Phenoldiphine D1 and dopoxamine in the D1 and the B2. Miragrebron is for the beta 3. Midodrine is for the alpha 1. Next, continuing with the sympathomimetics. So this is a normal action only. Sympathetic activity, it will increase the heart rate, decrease the urination, decrease the salivation that we have discussed, right? So sympathomimetics is opposite of epinephrine, norepinephrine. So stress and flight hormones only. So what it will do in the CNS, it will decrease the cognition. In the pupils, it will do the dilatation. And what are the drugs that will be acting on the pupils, guys? Phenylephrine and the ephedrine. This is also used for the fundus examination, but it has a very less synesthesia formation. So but we usually contraindicate when we are using in the glaucoma patients because it is causing the dilatation. Further, it can increase the aggravation of the glaucoma. So next, salivation, it will decrease the salivation. Sweating also, it will act to the acetylcholine receptors, especially for the sweat glands from the sympathetic system. For the bronchioles, it will do the bronchodilation. What are the drugs that we gonna use? Beta agonist drugs. So you must have heard that the formoterol, salbutamol, carmetrol, these all are going to be the bronchodilation only. Long acting beta agonist, short acting and very long acting. Okay, these are the drugs that we are going to use. And the side effects commonly will be hyperglycemia, decreased potassium, tremors and increased heart rate, cardiac activity will be seen in this patient. And terbutaline ritotrin is used as a tocolytics to decrease the preterm labor uh, in the pregnancy patients. For the heart, it will increase the heart rate, and epinephrine is one of the examples. And causes are the side effects are going to be the bradycardia and cardiac arrest sudden if we give the action of this epinephrine. And on the smooth muscles, alpha agonist is going to act like ephedrine, and which will decrease the heart rate and also spinal anesthesia. Phenylephrine, and it is going to be in the spinal anesthesia with the normal heart rate. Midodrine is used for the postural hypotension, and norepinephrine is going to for the neurogenic and also septic shock and cardiogenic shock. All these shocks we are going to use the norepinephrine as a drug of the choice. For the bladder, specifically beta 3 for the relaxation, the urge continence, whoever is suffering from the urge continence, we can give the mirabegron. This is going to act on the beta 3 agonist and it will relax the bladder. Skeletal muscles, it will increase the contraction. One of the example is a senbetrol. It will increase the performance. Those who are in the athletes know, they are going to take this selenbetrol, which will be increasing their muscle performances. Next, sympatholytics, that means opposite action completely. It is going to be the parasympathetic activity only. So CNS, it will increase the cognition. It can cross the blood-brain barrier, such as the beta blockers. Like one of the examples are brimonidine for the alpha agonist. Okay, why we are contraindicated this drug in the children? Because it can cause apnea, drowsiness and the depression. So that's why we are not going to give for the children. And next, coming to the pupils, passive miotics and prazosin is one of the example, but we less commonly use the prazosin for that use. And saliva and oral, it will increase the saliva, so obviously it is a contraindicated when we are going for the surgeries. Lungs, and it causes the bronchoconstriction. Beta blockers is one of the example, contraindicated in the asthma, COPD and the OLG, obstructive lung diseases. We are going to block these channels. Next, heart rate, it will decrease the heart rate and AV conduction. One of the examples are the beta blockers. Vessels, it will cause the vasodilation. What are the examples, guys? Alpha antagonist. Let's see one by one. Alpha antagonist, phenoxybenazimine. It is used for the pheochromocytoma. Phentolinamine, it is used for the clonidine withdrawal, cocaine hypertension, IV pheochromocytoma, and cheese reactions, which is associated with the thyrosamine. Next, alpha 1 blockers is used for the prazosin. Benign prostatic hyperplasia with the hypertension, we can use the prazosin, and even for the scorpion bites we can use the prazosin as a drug of the choice. Alpha 1a blockers, this is the tamsulosin, urinary bladder relaxation. What is the common side effect with the tamsulosin, guys? Retrograde ejaculation will be seen. Skeletal muscles, decrease the contraction, increase the relaxation, decrease the exercise tolerance. So these are the one of the important examples, and we are going to discuss about the OP poisoning and the atropine poisoning. What is the differences basically? OP poisoning is going to be the cholinergic activity such as respiratory secretions, meiosis, urination, defecation, decreased heart rate and temperatures. Mostly it is going to act on the acetylcholine and these drugs. Next, atropine. Atropine is going to be the opposite, anticholinergic activity. So, dry mouth, dilatation, dysuria, constipation, and heart rate is increased and temperature is increased. That is the atropine, anticholinergic activity. So, opposite to that, if you are suffering from the OP poisoning, what is the anticholinergic atropine? So, we are going to give the atropine for this patient. Along with that, paradoxine. What is this paradoxine? It will block the whichever already dead, no, it will revive those. So paradoxine can be added for this patient. Next, atropine. For the atropine, the physostigmine, which we are used now earlier in the muscle relaxants, we can give the physostigmine to decrease the anticholinergic activity. So this is the overall CNS and also parasympathetic nervous system important topics, guys. Please do read and revise. At least 2 to 3 MCQs are coming from this chapter only. Okay, I hope you have the overall and read the notes and also watch the previous lectures. And those who are new to this channel, please do subscribe and share with your friends. And all the best and happy preparation, guys.